I'm going to present 10-year results of the study that is a multicentric randomized trial, international one, of the IBCSG 2301. In 1990s, the treatment of breast cancer included axillary dissection as a staging procedure and also a regional treatment. But thanks to the sentinel node era that showed that the sentinel node can accurately staging the axilla, axillary dissection was abandoned, particularly in clinically node-negative patients. But the exhaustive examination of the sentinel node also revealed very small amount of metastases, that is called micrometastasis, whose prognostic value was very unclear. And so we designed at this time a trial, a multicentric international trial, to assess, to respond to this problem. And this trial randomized 936 patients from 2000 to 2011. And patient schedule or could be scheduled for mastectomy. This is the very things that can change the eligibility criteria according to 2301 in respect to Z11, and also breast conserving surgery. Patient eligible and consenting were registered before surgery, and if the sentinel node was micrometastatic, patients were randomized to receive axillary dissection or no axillary dissection. The tumor could be up to 5 centimeters. Multicentric tumor were allowed, and more than one micrometastatic sentinel node. The two groups were well matched for all characteristics, and particularly we have a good distribution, very good, a similar distribution according to the adjuvant treatment, and this indicating that the detail of number of nodes removed does not indicate the guide for adjuvant treatment. This is the news. The 10-year disease-free survival was very good. There was no difference between the two curves, and particularly the test of non-inferiority gave a p-value very significant, indicating that axillary dissection is non-inferior to non-axillary dissection. And so I think the same for overall survival, that we don't find any difference between the two curves. 91% of non-axillary dissection was alive, and 88% in the no-ID arm. And so our results can say that axillary dissection can be abandoned when the sentinel node is minimally involved, because the non-inferiority is fulfilled of the primary and the secondary endpoint, and particularly because the axillary failure were very low, 0.8% in the breast conserving surgery, those that didn't receive any axillary dissection, and 1.2 in the mastectomy group. And so this, I think that this trial provides a further level 1 of evidence that axillary dissection should be abandoned in those cases.